AJP Audio for April 2025. I'm Aaron Van Dorn. Today on the podcast, I spoke with Dr. Valentina Mancini of Oxford University. Dr. Mancini and colleagues have a paper in the April issue of AJP taking a closer look at anticholinergic burden in patients with schizophrenia and its impact on cognition. Afterwards, AJP Editor-in-Chief Dr. Ned Kalin will join us to discuss the rest of the April issue, which takes a close look at several different issues surrounding schizophrenia and psychosis. Dr. Mancini, patients with psychosis often exhibit cognitive deficits, and many drugs that are used to treat psychosis exhibit anticholinergic properties, which can exacerbate cognitive deficits. Indeed, even drugs not for the treatment of psychosis, antidepressants and antihistamines notably, can contribute to anticholinergic burden. You and your colleagues performed a meta-analysis of the available studies on anticholinergic burden and the cognitive deficits in patients with schizophrenia. What did you find?
So we know that multimorbidity and polypharmacy are highly prevalent in patients with schizophrenia, and this can lead to a substantial anticholinergic burden. Our meta-analysis found that the higher anticholinergic burden is associated with greater cognitive impairment across multiple cognitive domains in schizophrenia. Notably, we also found that evidence from tapering off anticholinergic medication can have a positive impact on cognition, highlighting the potential benefits of careful medication management in these patients. This paper is a meta-analysis, so it means we search for all the existing evidence in the scientific literature, and we try to make some statistics to see how robust these findings were. So we run three different analyses. The first was measuring the anticholinergic burden with existing scales and making a correlation with cognitive symptoms. And the second analysis were studies that were measuring the anticholinergic burden with blood assays. So they were measuring the quantity in the blood. And also we did a correlation with symptoms. And in the last one, we included studies that were measuring cognitive symptoms before and after tapering off medication with anticholinergic properties. So overall, all these results go in the same direction, showing that anticholinergic medications are not good for cognition, and that in cases when we are able to taper them off, we can give some benefit to the patients.
Do we know what the method of action are that causes the anticholinergic burden to have an effect on cognition in patients with schizophrenia?
Well, yeah, so there are many studies looking at the muscarinic system, so the cholinergic system in relation to cognition, but especially this has been done mostly in relation to dementia. In fact, in people with dementia, we give medication to increase the cholinergic neurotransmission, which is the opposite of anticholinergic medication. And these medications are used to counteract the cognitive impairment that is typical of people with Alzheimer's disease.
Many, if not most, drugs come with some form of unintended effect in addition to their intended benefit. Some guidance argues against long-term use of anticholinergic medicine in people with psychosis, but anticholinergic medicines are still routinely prescribed to people with psychosis as a counter to the extrapyramidal or movement-related side effects of antipsychotics. Does your study give any insight on how that balance should be weighed regarding anticholinergic burden?
For sure, there are certainly cases where anticholinergic medications are necessary to manage extrapyramidal side effects of antipsychotics. However, our findings suggest that the cognitive impact of anticholinergic burden should not be overlooked. So, given the association between higher anticholinergic burden and cognitive impairment, it is crucial to carefully weigh the benefits and risk on an individual basis, so it depends on the patient. But we think that whenever possible, clinicians should consider alternative strategies, for instance, adjusting antipsychotic treatment or using the lowest effective dose anticholinergic medication to minimize cognitive side effects while still managing movement-related symptoms effectively. Additionally, it's also important to assess the overall anticholinergic burden, so not just anticholinergic medications. So in cases where anticholinergic medications are really necessary, it is important to optimize the broader medication regimen by selecting alternatives with lower anticholinergic burden to mitigate the risk of cognitive impairment. And also, I think another important point is to avoid long-term use of anticholinergic medication whenever possible, because this can really exacerbate cognitive impairment over time.
How do you define long-term use of anticholinergic medicines?
Well, I've seen sometimes patients being anticholinergic medications for years. Sometimes it's just better try a few months, then reevaluate movement-related symptoms, and then see whether it's really needed to keep that medication.
What were the limitations of your analysis?
So as I said before, a meta-analysis is inherently limited by the quality of available existing data. So one key limitation, I think, is that we could have only analyzed variables that were reported in included studies. And this means that some important factors, such as, for instance, the presence and severity of negative symptoms, depression, and overall psychotic symptom burden, could not be taken into account in all our analysis. And we think this was very relevant given that individuals with more severe symptoms are also more likely to receive more medications and potentially have more anticholinergic burden. So we need more studies to assess this correlation.
Discussing the need for further studies, your paper concludes with a call for further research. And what areas do you think need more attention? Or are there any particular kinds of studies that strike you as the most needed?
Yeah, sure. So while studies demonstrating a correlation between anticholinergic burden and cognitive impairment are obviously very valuable, I think we really need more trials focusing on tapering off anticholinergic medication,
Hmm.
because this is really helpful to quantify the clinical benefits for patients.
Were there any immediate clinical implications for your research?
Yeah, of course. I think our research really underscores the importance of systematically assessing anticholinergic burden in clinical practice. So, given the known association with cognitive impairment, I think that clinicians should consider to routinely evaluate the patient's total anticholinergic burden, especially in those who are taking many medications. And this could really help guide more informed prescribing decisions, such as minimizing unnecessary anticholinergic use, considering alternative treatments, or even tapering off medications when appropriate.
What's next for your research?
So, as a group, we are currently working on a study to reduce the anticholinergic burden in people with schizophrenia. And this includes, as I've said before, not only tapering off anticholinergic medications when possible, but also optimizing the overall medication regimes to minimize cumulative anticholinergic effect. So, we think that by carefully adjusting treatment plans, we can assess the cognitive benefits of reducing the overall anticholinergic burden.
You said that there's a need for randomized controlled trials, but is there a need for any particular trial, or just how would you want to, what kind of information would you want to see out of a trial to further quantify these effects?
Yeah, I think the point is that there were only a few studies and the sample sizes were quite small, like,
Hmm.
I don't know, 10 to 15 subjects. So I think we need more robust studies in terms of numbers and procedures. But also, it's quite interesting. There are now new drugs available for the treatment
Hmm.
of schizophrenia, which have the opposite effect of anticholinergic medication. And it seems like preliminary results seems to indicate that these drugs, procholinergic drugs, are quite effective for cognitive symptoms, but also for psychotic symptoms. So this is certainly another future direction in research.
Well, Dr. Mancini, thank you for taking the time to speak with us today. Up next, Dr. Ned Kalin. Dr. Kalin, welcome back to AJP Audio.
Thank you, Aaron. It's a pleasure to be back.
This month, I spoke with Dr. Valentina Mancini about their paper looking at cognitive deficits and anticholinergic burden in patients with schizophrenia.
Yeah, this is a interesting and important paper and fits into the general framework of the issue, Aaron, which is focused primarily on psychotic disorders and schizophrenia. And the issue gets into the treatment, risk, brain alterations, and mechanisms associated with psychotic disorders. This particular paper highlights the importance of assessing an individual's so-called anticholinergic burden who is being treated for psychotic disorder, schizophrenia. Actually, this probably applies for any psychiatric patient, but mostly we use these medicines in patients that suffer from psychotic problems. This is a large meta-analysis to look at a variety of papers that have examined this issue. The idea here is that anticholinergic drugs, which we frequently use, or drugs that frequently have anticholinergic properties, by blocking the muscarinic receptor, also can impair cognition and memory. And so it's sort of a double-edged sword. The drugs that we use can be very helpful. This is sometimes one of the side effects. And some of the antipsychotic medications that we use, for example, have significant anticholinergic effects. Some of the drugs that we use to treat some of the side effects of antipsychotics also have anticholinergic effects and so on. And there are a variety of other drugs. Nonetheless, the authors looked at studies that have different ways of assessing anticholinergic burden. Some were based on clinical scales. Others were based on assessing the amount of dose that was used. And some actually were based on using a blood measure that can be much more quantitative. The bottom line was that regardless of the way that this was assessed, the consistent finding was across these various studies in the meta-analysis that anticholinergic burden is a considerable contributor to cognitive impairment. And so the take home from this is that when we're treating our patients, We want to make sure that we minimize the anticholinergic load, and also want to make sure, especially in patients that already may have cognitive problems or in illnesses that are associated with cognitive problems like schizophrenia. Now, I think it's important to point out that the cognitive problems in patients with schizophrenia are certainly not all due to anticholinergic medicines that they're taking. This is part of the illness, but also these drugs can exacerbate that. So, an important paper highlighting the clinical utility of assessing anticholinergic burden in patients and then trying to minimize exposure without increasing risk of relapse and illnesses.
Some drugs that people might not think about, such as antihistamines and antidepressants, also have an anticholinergic burden. Is that something clinicians should consider?
They can, and it depends on exactly which drug we're talking about. And throughout medicine and other types of medications in other fields that people might be getting, whether it's for allergies or other types of problems, these drugs that they might be getting may have some anticholinergic burden or effects. So it's important to not just look at antipsychotics. It's important to look at all psychotropic medications as well as all the medications that an individual is taking. This is especially impactful as well in the more aged populations because they're more sensitive to these effects.
Next, we have a paper from Tiihonen and colleagues that also takes a look at the burden of long-term treatments in patients with schizophrenia, this time focusing on D2 antagonist treatment.
Yeah, so this is sort of the flip side of the coin. In this paper we talked about side effects of drugs that can be impairing. This is a study looking at actually a rare opportunity to look at how patients do with schizophrenia who are continuously taking injectable long-acting antipsychotic medication compared to a group that was not treated that way. This is a large study from a large Finnish registry. There are roughly 4,800 patients that were admitted for their first psychotic episode, and these were all followed up for 10 years. 305 of these patients were documented to be continuously treated with long-acting injectable antipsychotics. So a real opportunity to ask, is that a treatment benefit to have this always on board, not having to worry about changing in plasma levels or changing in adherence to taking medicine? But also, there has been some concern raised that long-term blockade of dopamine 2 receptors can have significantly deleterious effects for people because it's thought that the receptors can either sensitize or maybe even downregulate. So this is an opportunity to ask the two questions. One is, are outcomes better? And two is, are there other bad things that are unintended that can occur with continuous long-acting injectable treatment? The answer to this is basically that nothing bad is happening. And as expected, the amount of time staying well or not relapsing, not being rehospitalized, is considerably better in the long-acting group. Now, just to give you a feel for this, of the 305 patients that were treated continuously, they had a 45% relapse rate over this 10-year period. The group that did not receive continuous LAI treatment had a 55.2% relapse rate. So there's another message here, which is even with a long-acting continuous treatment, we still have a lot of relapse in patients with schizophrenia. It's better than with not using that approach, but it's still there. So it highlights the importance of new treatment development.
Next, we have a paper from Zhou and colleagues, a meta-analysis looking at the association of childhood adversity and the incidence of psychosis in a very broad set of studies.
This is an interesting study too, and it's another meta-analysis asking the question whether significant early life adversity leads to greater levels of psychosis, or at least predisposes, which we've known about from various papers. And if so, do different types of adversity have different risks? Now, what's unique about this is that this looked at studies that were performed over the past 40 years. So this is a broad swath of research that has been done. And it also encompassed almost 350,000 individuals, patients, that were representative of studies done in 45 countries. So what I like about this is it's a huge sample that's looked at. It's looking at over a very long period of time where people have been studying this issue. And it also is not selective to one region or one country, but rather much more broad from a representative standpoint. The findings were, in a way, not surprising, but important. Across all the analyses, childhood adversity increased the risk of developing psychosis by about 2.8 fold. And regardless of which type of adversity it was, they all showed significant increased risk. But interestingly enough, the highest risk that was conferred was from emotional abuse, not physical abuse, not sexual abuse, but emotional abuse. The risk with emotional abuse was roughly 3.5 fold greater. Now, what also is interesting is that if one suffered significant childhood adversity and developed psychosis, on average, the onset of psychosis for that individual was sooner, earlier in life. And it was estimated to be about 9.5 months earlier. We know that childhood adversity is not a good thing, but this is more sort of consolidated evidence, across a large sample, across many years, across many countries, demonstrating this effect and also highlighting, again, that emotional abuse is right at the top there from the standpoint of increasing risk.
It doesn't seem like it needs saying that childhood adversity would have long-term impacts, but it's incredible to look at it and see the actual numbers.
Yeah, I should also point out that childhood adversity it's a non-specific risk factor for all psychopathology. So depression, anxiety, psychosis, bipolar disorder, and so on. So it's not a specific risk, but when looking at the specific outcome, in this case psychosis, these are the findings that we have about the increased risk.
Omlor and colleagues have a paper looking at brain structural variability in patients with schizophrenia worldwide.
So this is an interesting study. Now we're moving from risk factors and treatments to what's happening in the brain, and by using imaging and using again a relatively large sample. This is a study that was done by Enigma, which stands for Enhancing Neuroimaging Genetics Through Meta-Analysis. It's a consortium that is bringing together a lot of data sets related to psychiatric illnesses and genetics. What the investigators looked at was changes in brain structure that are associated with schizophrenia. Now, again, we've had many, many reports of reductions or changes in gray matter volume or cortical thickness or even white matter structure in patients with schizophrenia. What's interesting about this paper is that they demonstrate that what is also different is the variation in the structure in a particular brain region. And what they show is that schizophrenic subjects have greater variability or variation in a variety of brain structural measures in a certain region or regions as compared to a control population or control sample. So this suggests that not only may there be reductions or increases, but there's greater variability across this group. And this sort of gets at the idea that schizophrenia probably isn't just one thing, that there are lots of different subphenotypes perhaps. Some of the more specific findings were the areas where some of these findings occur, where there's greater variability in cortical thickness, for example, across the temporal, superior frontal, insula, and fusiform gyruses in the cortex. There were some areas where there's actually some decreased variability as well. The other thing of importance is some of these areas where there was increased variability, if you looked at the absolute value, it was usually associated with symptoms in the patients, suggesting that it's not just the variability, but also that this region and the changes that were being detected also may be related to symptoms at some. So this is a sort of a newer idea about not just looking at mean differences between groups or average differences, but asking the question, is the variation in one group for a measure greater or less than the variation in another group? And that's exactly what they found here in schizophrenia.
Finally, we have a paper from Orhan and colleagues looking at the relationship of synaptic loss and elevated production of chynurenic acid in postmortem patients with schizophrenia.
So this is, what I like about this issue is we have studies at very, very different levels of analysis. And we have large-scale population studies. We have studies looking at the effects of different medications. We have studies using imaging, looking at brain structure. And now this is a study looking at molecules. And it's taking advantage of the relatively new developments in stem cell technology and in organoid production. What's really interesting about this study is that the investigators wanted to explore whether this compound, chynurenic acid, may be a player in the development of schizophrenia. Now, why chynurenic acid? Chynurenic acid has been around for a long time in the literature. There have been a number of studies that have implicated the changes in the levels of this in the brain or in the plasma of individuals with psychotic disorders. And kynureninic acid is a derivative or a metabolite of tryptophan, which is part of the whole serotonin sort of series of pathways and so on. Also, the more basic studies have demonstrated that this compound affects the NMDA receptor, can antagonize it. It also affects the alpha-7 nicotinic acetylcholine receptors by blocking it. So it's got neurochemical neuromodulatory effects. It also has effects on how neurons can function at some level. So what these investigators did is that they used fibroblasts, skin cells, from 4 individuals that had schizophrenia. They took those skin cells and transformed them into what are called induced pluripotent stem cells. And then they took those induced pluripotent stem cells and transformed them into progenitor neurons or neuronal type cells. And they studied them in a dish. They looked at how they responded when they put kynureninic acid on them. And they also then took those types of cells and you can make them into 3-dimensional, what we call organoids, which have some structural relation between different cell types. And basically the bottom line is what they found is that when applying kynureninic acid, that there was a decrease in what they thought was considered neuroplasticity. And that is in the dendritic spine formation. They also found, and probably related to this, was that there was a reduction in the activity of the excitatory neurons in the culture. And finally, when they gave a compound like glutamate, which is an agonist for the NMD receptor, they found that some of these effects were actually rescued. So this is indirect evidence, and I'll underline indirect, that kynureninic acid could be involved in some of the processes that may be associated with schizophrenia. So you hear me say indirect, could be, and maybe. We included this paper because of the interesting components it's got, the method that's used, and the idea at a molecular level we can begin to implicate this particular molecule in processes that may be associated with the neurodevelopmental neurobiology associated with schizophrenia. So a very interesting paper in relation to that.
Dr. Kalin, thank you once again for joining us.
You're welcome. It's a pleasure to be with you.
That's all for this month's AJP audio, but there's more where that came from. Over on the Psychiatric Services from Pages to Practice podcast, Dr. Dixon and Dr. Berzin go deep on the concerns, practicalities, and the data regarding involuntary hospitalizations in urban police departments with Dr. Kevin Simon. Check that out, along with the other podcasts that the APA has to offer at psychiatryonline.org or wherever you get podcasts.
The views and opinions expressed in this podcast are those of the individual speakers only, and do not necessarily represent those of the American Psychiatric Association. The content of this podcast is provided for general information purposes only, and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.